afternoon, and today I want to talk about preeclampsia. Why is it a must know for you as a GP or a med student? Because it can lead to eclampsia, and eclampsia is a life-threatening condition for both the mom and her fetus. Preeclampsia is a pregnancy-induced hypertensive disorder that develops after 20 weeks of gestation. It is diagnosed when a patient has a blood pressure of 150/90 and proteinuria, or evidence of organ dysfunction like liver, kidney, hematologic or neurological symptoms, and placental dysfunction. Don't judge my Play-Doh brain, it's doing its best. Eclampsia is when a patient with preeclampsia develops seizures. If I want to simplify the whole story in preeclampsia, our main problem is vasospasm that leads to end organ damage. In cardiovascular and hematologic system, we have high blood pressure, thrombocytopenia, and third spacing of fluids. Renal effects are decreased GFR and proteinuria. And we have pulmonary edema and placental dysfunction. Diagnosis. What should we look for in a patient's physical examination and history? We should look for red flags. These are our red flags. Visual disturbances, persistent headaches, right upper quadrant pain, which may indicate liver involvement, and persistent edema, and also any history of loss of consciousness or seizures, which indicate eclampsia. Remember, what are we looking for again? End organ damage. So in laboratory evaluation, we should look for liver dysfunction, renal insufficiency, and coagulopathy. So those were our significant concerns and require serial evaluation. But in terms of management of preeclampsia depends on two factors: its severity and the mother's gestational age. Let's break it down by gestational age. More than 37 weeks, we deliver in all cases, no need to wait, because here risks outweigh benefits. But between 34 and 37 weeks, here it comes down to severity. In severe cases, we terminate the pregnancy, but in moderate cases, we can wait. We can monitor and hospitalize the patient till the 37 weeks. Unless mom or baby deteriorates, in that case, we have no choice to terminate the pregnancy. But what about less than 34 weeks? Preeclampsia under 34 weeks, it's like baking a cake that's not done yet, but the oven's on fire. Many experts recommend in severe cases we administer corticosteroids for fetal lung maturity, then terminate the pregnancy after 48 hours. Did you get it? Now think about it. Is there any situation in which we terminate the pregnancy without paying attention to the gestational age? Yes, if the mother or the baby's situation is critical, we have no other choice. Those situations are severe uncontrollable hypertension, pulmonary edema, DIC, IUFD, non-reassuring fetal status, and non-viable fetus, and placental abruption, of course, because the baby is unviable. That was all about when to terminate the pregnancy. But about the medical treatment, in medical treatment we have two main goals: to prevent eclampsia and to lower the blood pressure. To prevent eclampsia, we usually use magnesium sulfate. But to lower the blood pressure, we have two drugs. Our initial treatment is hydralazine, and for severe cases, we could use labetalol. Now let's put this into practice. Here is a real case from Beckmann. Type your answer in the comments and I'll pin the correct one.